Please welcome to the stage Phillip Berry, founder and CEO, Northwind Pharmaceuticals. Dr. Kyle Rickner, MD, owner, Primary Health Partners. Dr. Robert Lockwood, MD, owner, Primary Health Partners.
Thank you for being here this morning. We're excited about this. Does Hint know how to run a show, do a program, do a party? This is amazing. What a production. It's been great. So I'm Phil Berry, founder, CEO of Northwind Pharmaceuticals. We are a national pharmacy services platform that basically brings together the logistics of distribution and home delivery pharmacy and combines it with analytics, chronic care programs, the pharmacy benefit, as well as software to basically help employers create a nexus of care to influence costs and outcomes. So what we do is we fundamentally rework the RX part of it, aligning it with medical care, and point it at the problem areas so that, and we use the DPC practice, essentially, partner with them to become this nexus of care. So Northwind is national. We work with about 1,000 clinic groups, about 1,200 employers or so around the country, about 500,000 lives within our service set. So with me today are Dr. Kyle Rickner, Dr. Robert Lockwood of Primary Health Partners out of Oklahoma City. We're here to talk about pharmacy services as it relates to the DPC practice, the value to the patients, value to the employers, the value to what the practice is doing. So gentlemen, if you would, maybe introduce yourselves and tell us a little bit about PHP.
Sure, glad to be here. I'm Kyle Rickner, along with Dr. Lockwood. We started Primary Health Partners in 2016, and we started dispensing out of our office right away. And I think both of us would say that we underestimated the value that would bring to the individual patients early on, and later to employer patients. And it's become a critical part of our practice and our value offering. And it's been a great partnership with Northwind to grow with them. And we're excited to tell you a little bit about it. Even you unfortunate folks in Texas out there, there's ways to get around this where you can bring this to your practice.
I'm Robert Lockwood, and along with Kyle, we founded Primary Health Partners together in 2016. I really don't have much to add to what he said, other than I do want to ask a quick question. How many people out there that have the DPC practices are dispensing out of the office? Would you raise your hand? Okay.
All right.
That's good. Now, how many aren't? So we do have a few. I was a little bit surprised when from the Hint a report that was given that only 53% of DPC practices are actually dispensing. So I'm hoping that after today, some of you guys that aren't, if you can easily do it, you'll be enticed to start doing this.
Can you tell us just a little bit about the scale and scope of Primary Health Partners, locations, panels, just to give everybody a sense for?
Sure. So we have 4 active locations. We're about to add our 5th location this month. We'll add a 6th location in October. We will have 18 providers at that time. We take care right now of about 7,500 direct primary care patients, and it's all in and around the Oklahoma City area.
Great. So one of the things that we've seen with this particular group is how they've leveraged pharmacy as a part of their practice. So would you characterize for us how pharmacy services that you're providing, the value they're bringing, where they fit, how they meld with the way your practice patterns are, where you use them relative to patients as well as to employers? Kyle,
sure, I'd love to start by telling you about Roy. Roy was a 84-year-old patient of mine, a diabetic, hypertensive, hyperlipidemia, and he got 5 to 6 meds a month through our office. And as we were doing this, I started to ask him, I said, are we actually saving you money with your Medicare plan on this? And he grinned. Oh yeah, he said. And I asked him, I said, are we saving you enough that you're covering the full cost of your membership? He said, and then some, doc. And I said, so I'm making you money by being your doctor? And he said, absolutely. So that's early on, we saw the value at the individual level. The exciting thing is we progressed from counting pills early on, which we didn't mind doing. When you buy in bulk, as some of you know, you can get incredibly cheap. Well, I remember the month that we went over 900 prescriptions to fill that month in our offices, and the labor intensiveness of the bottles and the labels and the counting. It wasn't a scalable method that we were using. And so that's when we started evaluating packaging partners and ended up with Northwind. Well, fast forward a few years later, and although the cost went up some, a lot of people are concerned about that. Well, that's going to cost my patients more. Well, we found the $2.50 prescription that went to $4. Nobody cared. It was still the best price they could get out there. And now here we are with some of our larger employer groups that have decided any of our beneficiaries that come to your clinics and get a prescription, we're covering it 100%, and we're able to invoice them separately for that. And so now we're bringing increased value to large health plans and increasing the value proposition of DPC. And to me, that just buys us long-term employer relationships.
So Kyle didn't really go into too much. I am the nerd totally.
Amen.
So what I did was I actually figured out how much it was costing us to count pills, and it was actually going to save us money by buying all of our meds prepackaged and just dispensing them in that way. And it certainly made it so much easier for us and the staff to do it. So yeah, I went through that process. For you guys are still counting pills, I really encourage you. I understand if you have plenty of time, you don't have very many patients, it's easy to do and all of that, but it was almost funny to watch us in the morning as patients would call for refills to have one of our staff in there running our little pill counter and pills shooting all over the place. And it was comical. And I just looked at Angie, who used to do that for us, and I said, there's got to be a better way. So.
Great addition. I know you guys do more than just have medications on site. So tell us how it works, how drugs are a part of your practice in terms of how you implemented it, how it flows, how broadly you go. One of the concerns, of course, is I can only put a limited number on site. What else are you doing to kind of supplement what it, maybe Robert, you want to lead us on this one?
So if you're asking like what did the relationship with Northwind, where did it take us? I think one of the most important things was we quickly realized, because of our retail patients, the value of what we were doing for them could be easily transitioned over to the employer side. So and one of the major value propositions when we were going into employer groups to sell our wares, so to speak, was we have this pharmacy benefit for your employees that they'll want to use. At first, we were thinking just along the lines of it'll be cheaper here, they can get it from our office, they'll pay us directly, it'll just never hit your health plan. So we used to sell it that way at first. But then as we worked closer and closer with Phil and Northwind, what we realized is that, there's more to this value of our relationship with the pharmacy and what it can do for employers. So do you want to go into that a little bit, Kyle?
Yeah, so one easy thing that occurred is actually partnering alongside them. They were able to develop a wonderful process of being able to do home delivery. And, you know, when we send a prescription to Northwind, the patient gets a text that day. They call in, they give a payment source, and they can start getting their meds at home. You know, we found that a lot of foot traffic in our clinic, which consumes staff time, was taken up by people coming in and out all day long picking up prescriptions. And that's not a horrible thing. I mean, part of it we like because they love to come to the clinic. Patients actually like coming to the doctor's office now, sometimes just to say hi. But with the efficiency of home delivery with chronic meds, that added just another layer of efficiency and convenience that we felt was very patient-centered. And often that can save them money because we have to mark up to a certain point to, again, the nerd is doing the math, and we have to cover our cost of our staff time and all that goes into filling a prescription. And so oftentimes they can get it cheaper through home delivery.
So around the employer side, so a lot of what we're talking about today is how to use this to drive value from an employer perspective. We also have patients and so forth. So this is also about growing your practice. So as you guys look to expand, I know you've got another one coming online here soon, and you have other aspirations. Do you see, is pharmacy part of a broader strategy as you approach employers? And how do you go about doing that?
Phil, I'm glad you asked that, because beyond what we've described to you, and now that we've had employers utilize this service to its maximum extent to where any prescription that they get from us is free, that's a great employee benefit. But now, looking forward, and one of the things that we've enjoyed the most with building relationships with employers, excuse me, is the trust. And so as they're trying to manage and design their self-funded plan, the beauty of it is they will turn and look to us and go, is there anything else that you think we could be doing? Is there any other cost savings opportunities? And Northwind offers expanded pharmacy services with pharmacy consultation, and now an offering of actually being a PBM to self-funded employers. And so to be able to bring that into the conversation, and because not everything we can do, right? There's still very expensive meds out there. And although we can have a heavy impact at the point of care and with some of the generic meds, there's still some opportunity for value to the employer by using a trusted partner as a PBM, which is kind of bamboo under all our fingernails sometimes trying to deal with them, right?
And I think it's important. Some of you guys may be thinking, I'm anticipating a question of, so how do you get the cost of the pharmacy benefit back to the employer on the patient? And actually, what ended up happening is Hint, we use Hint, was realizing the value of direct primary care practices actually sort of creating their own little mini health plans back to the employers. They were able to put that as an automated feature in Hint. And so the patient doesn't need to get reimbursed or anything like that. It just goes directly and invoiced directly to the employer.
So around this notion of nexus of care, I had a chance to interview both of you for the book. Thank you very much. Great addition. So I think an interesting concept from an employer perspective is how your services, what you bring to bear, can provide that point of influence for the population of the employers. And as you move towards that, what do you see as the key steps as you kind of go to an employer and talk about what your practice can do, not limited pharmacy-wise, but as an influence across broader population health?
Kyle, you probably should take that one. You're in the room with him more than I am.
Yeah. So, that we could spend another half hour answering this question. I'll try to be brief, but the very first step is education. Most of them don't understand how to do this. It doesn't fit in the normal paradigm. And so we actually actively try to get a face-to-face meeting. Once we get the face-to-face meeting and we can explain how we provide comprehensive primary care services, and then to begin to explain the steps of influence into their employee population. Yes, the convenience is there, but the increase in presenteeism at work by the use of virtual electronic visits, the decrease in absenteeism, and then the utilization of unnecessary urgent care or emergency room services and things like that. We tell a compelling story. DPC is a compelling story, and I don't disagree with our speaker yesterday that talked about that. But it's been exciting for us to have some tangible data information about the impact that we've had on employers' cost plans. And so we will highlight that. We want to highlight the convenience that we bring, the accessibility that we bring, but also the cost savings. And we try to leverage every service that we can to that regard. We do draw labs and we use a client-based lab contract. And so what employers have done with the pharmacy, they've also now done with the lab. This year, we are piloting for the first time a built-in physical therapy option that we're brokering for an employer. And that's going very well. And so I think the power of DPC is how much can we bring into our house? What can fit under our roof that enhances the value? At the same time, we're not doing a shared savings model on any of these services. That's a slippery slope that we don't want to play. I want to bring increasing amount of value so that the relationship is sustainable in a way that if there's, it would almost make them impossible to get rid of us, So I want to make it too good for them. And so those are kind of the steps that we do. I will tell you one very important thing, just kind of as a tidbit, a strategy, if you will, that we've started using. If we get in front of the decision makers, we offer them free memberships for a period of time. Just come try it out. It has never failed. They never come away going, yeah, I prefer the other way. They're like blown away. And so if any of you get in front of a decision maker, just say, hey, come try it out. Here's 3 months, free membership. Come in, have a visit, establish care. And we may do that with 2 or 3 of the key executives in a company, and that works very well. You want to add anything?
Yeah, just briefly, he described that whole process there for us, but since this is about pharmacy benefits, I think it's super important for us to highlight this fact. I know every DPC doctor here has a client-based lab contract, and they utilize that a lot. And when they go out to employer groups, they probably talk about that, and the employers are always shocked at the savings. Well, the same thing is happening on the pharmacy side now, because they're wanting more and more services for us to help them more and more, basically. And so when you highlight that as well, they're like, are you kidding me? We can do that? Yeah, we got to figure out how we can just pay you guys directly for that.
I think just to summarize, to characterize it, when I talk to them, I say we are unequivocally patient-centered, but we are plan-friendly. Yeah. And we make it our business to know your business. So let us help your employees and you use your health plan when it's appropriate and avoid it when it's not. And that often will resonate with the decision makers in the room.
Great. So we've got just a few minutes. Thought we'd give the audience a chance to ask any questions they might have and see what we can do.
Thank you, gentlemen. This is great. So as you integrate and you use the reference PBM, you've got the brokers and the plan sponsors who are using a healthcare system that has the PBMs. They're integrated. They're deeply woven in. How much resistance are you facing with existing channels to move over to yours?
So the story I highlighted was, I'll just paint the picture. So we're in our 3rd year with this group, and they invited us to the table to meet with their broker and their TPA to discuss next year's plan. And those 2 elements were virtual. We were in person. When the meeting ended, they dismissed their virtual clients, and then they turned to Sharon and myself that were in the room and said, what other suggestions would you have for us? What other opportunities are there? And so that's when we brought up the PBM. It's something that you should at least evaluate. And we give them the information and let them run with it. And so it really isn't resistant when the employer themselves, the actual payer, is asking. If you're trying to come at it from the outside in through the broker, you're right. You're going to get a ton of resistance.
Good question. Anybody else?
Hi, I practice in a major city where real estate is extremely expensive. It's a silly question, but how much space do you have to have in order to do this? Like, do you need a separate room? Can you double use? Like, how do you work that?
That's a really, really good question. I never really thought much about it. It's the space that we operate our pharmacy out of. We have about 120 medications or so in it. I'm going to guess about 4 by 8. So we just have them lined up on the wall in bins, and it's pretty simple. And the process is actually very, very simple. I'm sure it's similar with others, but with Northwind, basically we have our formulary set up. They know how much we have of each thing. The orders are set automatically. They come in, we look at it, make sure everything came in, hit a button. It takes, literally maybe 10 minutes of work.
Let me add something. He mentioned we're going to have a clinic opening this month. We're trying to move towards a more efficient type of operation in every area. That new clinic's going to have 30 to 40. Yep. And then you're talking about you just need some cabinet space and countertop space for a printer. It gets really simple.
So as we realize the value of the home delivery, and actually it saves money, we're transitioning to keeping more acute meds in-house.
One other question, does it have to be locked? Like, does it have to be in a section that's separate from where patients can get to? I'm sure people are not, stealing valsartan and selling it on the black market, but I just wasn't sure what the policy was.
Man, I couldn't hear her question.
Were you
I'm sorry.
asking if they're locking cabinets?
Yeah, do you have to?
Yes, so we have it in a locking room.
But let's be clear, we keep no controlled meds on site. Don't recommend that at all. Yeah.
Please, probably one more here.
So my question is, when you're approaching employers and you are passing that cost along to them for pharmaceuticals and physical therapy, is that something that is built into their overall price per patient, or is it estimated? How do you do that?
No, those are separate invoiced items as they're used. So it's just a way that a cost of a given medicine, if it's filled for a patient at our point of care, it's invoiced at the end of the month to the employer. The patient doesn't have any cost. The physical therapy, when it's ordered by us, there's a charge for that session, and that again gets invoiced to the employer separate. So it's not built into the monthly membership fee. That's a great question.
Well, the beauty of DPC is you get to set it up however you want. If you want to say it's $5 more a month per member or whatever, you could do that too. All your meds are free. And here's the formula of what is free. Yes. Yeah, so
Okay.
We get data. All this is data-driven, always data-driven.
She was asking if we use data from their plan. So we love to see employers' pain points, right? When we're talking to them, pharmacy is almost always a pain point. And so we try to look and see what the cost savings opportunity is in that area.
All right, that's all we've got. Thank you, everybody. If anyone's interested in kind of learning more about what they've described, it's actually captured well in a book. And if you drop by our booth, anybody who shows up and asks, we'll get you a copy at no charge. So thank you, everybody. We appreciate it.
Thank you.